Good morning, everybody. Thank you. I'm also continuing on that line Thomas was just outlining to you. He has very nicely explained to you how the new Pentacam AXL is working. And I want to share with you also some comparative data. And I will kick off this with a little case report because I was very much impressed by the pre-cataract screening possibility that you have and what you can look at, especially if you think about using it for multifocal lenses, aspheric lenses, or any kind of astigmatic correction. So we have a huge number of things we can focus on when we go, especially into like refractive lens exchange, stuff like this. The presbyopic lens exchange is actually now quite a big thing in Europe. And with the new technologies that arise from the Pentacam, we are completely independent from other devices such as the IOL Master 700, which we use, and the whole IOL calculation process is now on the same level as we had it. So let's look here at a typical patient that can come in our clinic. 55-year-old male patient. If you look on the one side, his uncorrected distance visual acuity and uncorrected near visual acuity is not bad, actually. Yeah, 20/30, 20/25, 20/60 for the near. So he has to wear reading glasses. He would get along without glasses in daily routine. But if you look on the other side, with a slight hyperopic and astigmatic correction, this patient goes up to 20/16 in his visual acuity. And you may be hesitant even to touch an eye like this, but the reality is that the patient runs around with the uncorrected visual acuity and is driving car and everything with that. So if you want to touch this kind of patient, you have to reach excellent results. You cannot end up with plus minus 3/4 of a diopter of astigmatism or hyperopia when you just do your normal IOL calculation. So our routine workup normally would be that we use the IOL Master 700. You see here, for example, for the left eye, the data that we have, the axial length, the keratometry. The IOL power in this case was 20 diopters calculated by the IOL Master 700. And you see here we are exactly at emmetropia, minus 0.01 diopter would be the calculated refraction. These are here some exams from the Pentacam. This is not a special thing, nothing really surprising here on the cornea, slight astigmatism, but really not much. So the patient, based on the IOL Master 700, got his first lens in here, the Artilisa 3, 20 diopters. The results after 3 months, when everything has settled down, when refraction came to its final end, here was 20/25 for distance and near. Well, this may look quite good, yeah, but he was 20/16 before, and as you can see, he needed 1/4 of a diopter to achieve 20/20. What would have happened if we looked at the Pentacam? So if we look at this here, we had a slightly shorter eye here, 23.84 instead of 23.92. The keratometry was very similar. We are not really having a big thing. But if you look at it, the IOL power calculation exactly predicted where the patient ended, a slightly hyperopic plus 0.2. So the Pentacam was right, more or less, with its calculation. And if you would have used the Pentacam for calculation only, I would have chosen actually suggested IOL power of 20.5 diopter. And with that, I would reach 20/20 uncorrected in this patient, which in this case is crucial for this patient. So it's quite interesting to see that it's just a slight difference, but maybe the difference between have to wear glasses or have full visual acuity. And especially if you consider a legal case, he more or less lost 2 lines, so to say, in this case. And with that, he wouldn't. Well, luckily, the patient has 2 eyes and the binocular performance. What did happen to the other eye? And here we see again the direct comparison, as I just said. The difference was half a diopter. Now let's go to the other side, the right eye. Here we have exactly the same axial length like on the other side with the Pentacam, with the IOL Master, 23.92. and more astigmatism. Here we are at like 1 diopter, and if I put in a trifocal lens in a case like this, between 0.75 and 1 diopter of astigmatism, I go for a toric version, because if you have residual astigmatism of around 3/4 of a diopter, it will have an impact on the visual outcome. So here we had to decide on the IOL Master to go for it. There's a slightly less astigmatism here in the Pentacam. However, we went with the IOL Master data. We ended up here with the calculation of a suggested IOL power of 20 diopter and 1.5 diopter toric correction. The spherical equivalent in this case would have been 20.75, as you can see here. And we put in this lens, the 3 toric version, and we ended up uncorrected after 3 months exactly at 2020, and near acuity was 2025. So with both eyes together, the patient actually ended up at 2016, so he really was uncorrected the same way he was best corrected before, which is a successful treatment of a presbyopic patient. So with the Pentacam, we would have gotten actually the same result. As you can see here, we had exactly the same spherical equivalent in this case, and here we would have used the same lens using the AXL calculation compared to the IOL Master. So in this little case, which may sound not so special, but if you really look at it, these are the fine-tuning that you do when you do presbyopic lens change in clear lens patients. We could see that the first eye, we would have better gone with the Pentacam AXL compared to the IOL Master 700. However, of course, we're complaining here on a very high level because we ended up nicely with both. So let's go and see how the Pentacam and the IOL Master 700 compares. We just recently presented some data at the ESCRS here. That's an ongoing prospective study. We were analyzing 163 eyes here. We had no exclusion criteria, so everybody who walked in. So this is kind of a real-world scenario, including also patients who are not so cooperative, who are moving their head, or patients that had some other surface diseases, stuff like that. So nothing was excluded here. 3 consecutive measurements. The measurements were done more or less untouched eyes, so we don't do any kind of examination before that type of measurement. This is a normal population, as you can see here. And the interesting thing was, if you look here at the axial lengths, that there are still patients that, even though the IOL Master 700 is an improvement compared to the previous version and can almost measure everybody, you still were inferior actually. If you look at it, 85% for the first measurement, 79 for the third or second measurements, and the Pentacam could measure almost 90% directly of all these patients. So this was quite interesting for me to see, because I was assuming that the IOL Master, being a higher generation and more or less peak development of the IOL Master, should be much better. If we go to the repeatability, you can see here the average values more or less were all the same. Slightly less standard deviations and less outliners by the Pentacam, but in general, you could see that we have the same type of repeatability, and as I said, with axial lengths, slightly more accuracy with the Pentacam. If you look at anterior chamber depths, horizontal white to white, there was a slight difference in terms of the white to white on average. Well, that would almost qualify for maybe changing and faking IOL at individual patients, as you can see here. Nevertheless, the overall analysis didn't show any significant values here. And the keratometry, you see the differences are slight, so to say, there's no difference between both devices. And again, if you look at all the variables concerning the accuracy, the Pentacam really performed very well. Astigmatism, we kind of separated between those below and those over 0.75 diopters. As you can see here, there was no significant differences in the accuracy of both of the machines. So as a matter of fact, these results now show you that you don't really need an IOL Master 700 anymore, because you can do exactly the same work with the same repeatability, the same accuracy, with the same margin of error, so to say, in a real-world scenario with patients just walking in, and the accuracy of both devices is completely comparable, and there are no differences if you look at this. So thank you very much for your attention.